This next section of Step 2 High Yield will focus on chronic obstructive pulmonary disease, also known as COPD. COPD is a disease characterized by airflow obstruction secondary to emphysema and/or chronic bronchitis. Emphysema and chronic bronchitis are really part of the same disease process. It's just that they are two slightly different manifestations. Firstly, emphysema is defined by terminal airway destruction resulting in decreased elastic recoil of the lungs. In the normal healthy lung, elastin fibers are what allow for passive exhalation. In the emphysematous lung, this terminal airway destruction actually results in destruction of the elastin fibers as well, and hence decreased elastic recoil of the lungs. You can imagine that if elastic recoil of the lungs is not working so well, there is going to be obstruction to exhalation of air. Chronic bronchitis is defined as a productive cough for greater than 3 months per year for 2 consecutive years. Both emphysema and chronic bronchitis are part of the COPD spectrum. They result in a decrease in the FEV1 and the FVC with an increase in the TLC. The FEV1 is the forced expiratory volume in 1 second, the FVC the forced vital capacity, and the TLC the total lung capacity. You can imagine that obstruction to exhalation of air is going to result in a decrease in the FEV1 and the FVC. These patients also, over time, because of their extremely poor ability to exhale air, are going to develop air trapping, their residual volumes will increase, and hence their total lung capacities will increase as well. The major etiology of COPD is tobacco smoke. This leads to almost all cases, and that's because tobacco smoke destroys elastin fibers in the lung. If you have a patient, however, who is young and a non-smoker, the correct answer on Step 2 is almost always going to be alpha-1 antitrypsin deficiency. With a deficiency of this enzyme, you're unable to break down certain molecules in the lung that destroy elastin. If you're unable to break those molecules down, you're going to have an excess in elastin destruction. And this leads to a clinical syndrome very similar to emphysema in a tobacco smoker. COPD typically presents as shortness of breath worsened by exertion. It is generally a disease characterized by intermittent exacerbations with increased cough, sputum, and dyspnea, all of which are often brought on by infection. These patients on physical exam will be noted to have a barrel chest or a wide expanded chest wall. This is again because of increased air trapping and the inability to effectively expire air. They often have muscle wasting and cachexia, and that's because, as we've learned more and more in recent years, COPD is actually an inflammatory disorder that can result in systemic symptoms such as wasting and cachexia. As we discussed with asthma, the USMLE Step 2 will often test us on what is the best initial test to order in a certain clinical scenario. In the case of COPD, a chest x-ray is a logical choice, mostly because these patients will present with shortness of breath, large amounts of sputum production, and a cough. Pneumonia is definitely on the differential and must be ruled out. Most often on a COPD x-ray, you're going to see the following: an increased AP diameter, which, as we already discussed, is a result of this hyperinflation of the lungs, an increase in the total lung capacity with years and years of expiration obstruction. You will also see air trapping and flattened diaphragms. Air trapping is usually seen as hyperlucency in the upper lung lobes, as seen on a chest x-ray. The flattened diaphragms, as pointed out by the blue arrows on your screen, are typical of a COPD patient, and these flat diaphragms can actually worsen the respiratory mechanics of these patients, and that's because a flattened diaphragm does not work as effectively as a nice, rounded, dome-shaped diaphragm seen in a healthy patient. If we ask ourselves a slightly different question, which is what is the most accurate diagnostic test for COPD, the answer becomes pulmonary function testing. In COPD, PFTs will reveal a decrease in the FEV1 and the FVC, and most importantly, a decrease in the FEV1 to FVC ratio, which must be less than 70% in order to diagnose COPD. In addition, you'll see an increase in the total lung capacity. As we already mentioned, these patients are going to have a large degree of airflow obstruction, and because they're unable to expire the full amount of air over time, they start to develop an increase in their residual volume. With an increase in the residual volume, you're going to see an increase in the total lung capacity. In patients with emphysema, there will be destruction of the alveolar septae in the terminal airways, and this happens to be where the capillaries of the lung are found. So with destruction of capillaries, you can imagine you're going to have poor diffusion of gases across that membrane. With poor diffusion of gases into the bloodstream, you're going to see a decrease in the amount of oxygen being delivered from the alveolus into the capillaries of the lung. On pulmonary function testing, we use the diffusion capacity of carbon monoxide, or the DLCO, to estimate the degree of alveolar destruction seen in emphysema. Lastly, you're going to see incomplete improvement with albuterol in a patient with COPD, whereas a patient with asthma is going to show good amount of reversibility when administered albuterol. Similarly, there's no worsening or only some small degree of worsening if you administer methacholine. If you recall back to our asthma lecture, you'll remember that while asthma is primarily a disease of reversible airway obstruction, some patients with chronic asthma can develop a degree of chronic inflammation and a chronic fixed obstruction. Similarly, patients with COPD generally have an irreversible airway obstruction. However, just like asthma can go both ways, so can COPD. Some patients with COPD will have a broad response to inhaled bronchodilators, for example albuterol. This can range from no reversibility whatsoever, which is the classic teaching for COPD, to complete reversibility. And those patients with COPD actually do have some very large degree of reversible airway obstruction. For these patients, on PFTs, you're going to see a greater than 12% increase in their FEV1 if you give them a bronchodilator such as albuterol. For these types of patients, you want to give them albuterol or the long-acting version, salmeterol, to better treat their COPD since they do seem to have some degree of reversibility. Continuing on with further diagnostic tests for COPD, the ABG, just like in asthma, becomes critically important. Acute exacerbations are going to be associated with a large degree of carbon dioxide retention as well as hypoxia. Remember, respiratory acidosis may be present if there is not sufficient metabolic compensation. The bicarbonate level will be elevated to compensate. In between exacerbations, not all patients with COPD will retain carbon dioxide. However, some patients will, and the patients who are chronic carbon dioxide retainers will show some increase in their bicarbonate level because the kidneys will be compensating for this chronic respiratory acidosis over time. The pH in these patients will be close to normal at around 7.4. In terms of cardiac testing for patients with COPD, both the EKG and the echocardiogram can be useful. As we'll discuss in a future lecture, patients with certain types of lung disease are prone to develop pulmonary hypertension. As you can imagine, chronic pulmonary hypertension is going to result in increased afterload on the right side of the heart, and both the right ventricle and the right atrium are going to hypertrophy and dilate over time. The EKG will show right atrial hypertrophy as well as right ventricular hypertrophy. Sometimes patients with COPD can end up in atrial fibrillation or a multifocal atrial tachycardia, and MAT in particular is very commonly associated with lung disease. The echocardiogram will show right atrial and right ventricular hypertrophy, as well as evidence of pulmonary hypertension.
In COPD, there have only been 2 interventions that have been shown to improve mortality and to delay progression of disease. The first is smoking cessation, and the second is oxygen therapy. The indications for oxygen therapy in COPD include the following: having a PaO2 less than 55 or an oxygen saturation less than 90%, or having a PaO2 less than 60 or a SAT less than 90% if the patient has pulmonary hypertension, cor pulmonale, or polycythemia. And remember, the mortality benefit from oxygen is directly proportional to the number of hours that the patient actually uses their oxygen.
In addition, a number of therapies have been shown to decrease symptoms for these patients, but do not decrease disease progression. The first of these is short-acting beta agonists, such as albuterol, which are particularly helpful for those patients who do have some degree of airway reversibility in their obstruction. Anticholinergic agents, tiotropium, which is long-acting, or ipratropium, its short-acting version, have been very helpful in COPD symptoms. While we mentioned before that these are not so well studied for asthma, they are very well studied for COPD. Inhaled steroids can be helpful to decrease the degree of inflammation in these patients and to prevent COPD exacerbations. And long-acting beta agonists, such as salmeterol, can also be helpful in preventing COPD flares. Lastly, pulmonary rehabilitation can be quite helpful in helping patients to improve their quality of life when living with COPD. In order to better understand obstructive lung diseases, it's often very helpful to compare asthma with COPD. And the treatment in these 2 diseases, while quite similar, is actually different in the initial steps. In an asthmatic whose disease is not well controlled with albuterol alone, as we already discussed, the first step is going to be to add an inhaled steroid. In a patient with COPD who is not well controlled with albuterol alone, you're going to go ahead and add an anticholinergic agent such as tiotropium, a long-acting version of ipratropium. If that does not relieve the patient's symptoms with COPD, you then add an inhaled steroid. Inhaled anticholinergic agents are most effective in COPD, although as we said before, we do sometimes use them in asthma. In addition to those therapies already mentioned, there are a few other that might improve symptoms for some patients, but again, are not shown to change disease progression or mortality. The first of these is theophylline, which we already mentioned as being used for asthma as well. Lung volume reduction surgery, which involves cutting out portions of the upper lobes in patients with upper lobe predominant disease. This can actually help the rest of the healthy lung to expand and can help patients with symptoms, but again, no effect on mortality or disease progression. There are some drugs that you should be aware of that have no benefit whatsoever in COPD. These include cromolyn, leukotriene modifiers such as montelukast, and you should be aware that when all medical therapy is insufficient, the correct answer is going to be to refer the patient for lung transplantation. In terms of an acute exacerbation of COPD, the treatment is actually quite similar to an acute exacerbation of asthma. You're going to be using a combination of bronchodilators, often in the nebulized form, and systemic corticosteroid therapy. COPD, in the setting of an acute flare, the treatment is identical to asthma. However, there is less proven benefit. One difference is that antibiotics are often considered in the setting of a COPD flare, while these are rarely used in the setting of an asthma flare. In a patient with a moderate to severe COPD flare, antibiotics are indicated. We define a moderate to severe COPD flare as the following: requiring hospitalization or having at least 2 of the 3 cardinal symptoms of a COPD flare. These include dyspnea that's increased from the patient's baseline, sputum production increased from the patient's baseline, or a change in the sputum purulence from the patient's baseline. So for example, the patient might make clear sputum on an everyday basis, but for the few days prior to their COPD flare, they started making green or brown colored sputum. That would change the sputum purulence and would count as one of the cardinal symptoms of a COPD flare. So, for any of these indications, you're going to use antibiotics to treat the COPD flare. In terms of which antibiotics to choose, we must remember that while viruses cause 20 to 50% of episodes of COPD flares, our antibiotic coverage should be targeted against strep pneumo, H. flu, and moraxella, these being the three most common bacterial pathogens to cause a COPD flare. Therefore, macrolides, such as azithromycin or clarithromycin, are first-line agents, cephalosporins like ceftriaxone or cefixime, amoxicillin clavulanic acid, or quinolones, such as levofloxacin and moxifloxacin. In terms of second-line agents, for patients who might have an allergy to the above-listed agents, we can use doxycycline or trimethoprim sulfamethoxazole. Before we end this lecture, it is worth briefly discussing the role of oxygen in the acute setting of a COPD flare. We must note that the hypoxic drive elimination concept is incorrect. Oftentimes, we are taught that we should avoid reflexively placing a patient with COPD on a very high-flow, 100% non-rebreather mask. In other words, we want to avoid putting these patients on extremely high concentrations of pure oxygen for very long periods of time. Because patients with COPD end up retaining carbon dioxide chronically, they lose their hypercarbic drive to breathe, and therefore in their brain stems, it's hypoxia that stimulates them to continue breathing. The fear is that if we put large amounts of oxygen on the patient, you're going to remove their hypoxic drive to breathe, and without a hypercarbic drive to breathe, they'll stop breathing. This is only true again if you use extremely high concentrations of oxygen for long periods of time. In general, the hypoxic drive elimination concept is incorrect, and in fact, oxygen is quite indicated in the setting of an acute COPD flare. The best way to use it is to only use as much oxygen as is necessary to raise the PO2 to above 90% saturation. Remember, dyspneic, hypoxic patients with COPD must get oxygen.